So I'm going to go ahead and introduce our panelists, and then they will just go through their different parts of the talk. Dr. Adam Isacoff is a pediatric emergency medicine specialist with Norton Children's Emergency Medicine, affiliated with the U of L School of Medicine, and he's also the Associate Medical Director in the Division of Emergency Medicine at Norton Children's. Dr. Arpita Lakotia is a child neurologist with Norton Children's Neuroscience Institute and an assistant professor at U of L. She serves as the Director of Pediatric Stroke and Neurofibromatosis Clinics, as well as the co-director of the Norton Children Medical Group Neuroscience Institute MDA Clinic. Dr. Karen Moeller is a pediatric neuroradiologist with Norton Children's and is acting director of the Neuroradiology department at Norton Children's. She has been voted by her peers as one of Louisville Magazine's top docs for 2019. And then Dr. Anna Thaman is one of our PGY5 child neurology residents and is our education chief resident. So thank you, Dr. Isacoff, and welcome.
Hi, good afternoon. Can everyone see my slides? All right. So basically, we're going to discuss some of the initial assessment of stroke that we see in the pediatric emergency department. We're also going to go through some of the stroke protocol that we have developed as a team, and certainly want to just give a shout out to my colleagues within the pediatric neurology, pediatric radiology, and pediatric neurosurgery departments and divisions to put this all kind of together. But I think what I kind of want to go over is the initial presentation, what we see in the emergency department to initiate the stroke protocols and the bad alerts. So we see it a lot in kids with certain risk factors, mainly heart disease, problems with blood vessels supplying the brain, blood clotting disorders, and sickle cell disease. In the physical examination findings, it typically begins pretty suddenly. The symptoms that we may hear about are a weakness or a numbness to one side of the body, a slurred speech or a difficulty with language, trouble balancing or walking, vision problems such as a double vision or loss of vision, or a sudden lethargy or drowsiness, more of an altered mental status picture. So we can kind of subclassify some of the physical exam findings that we see, first kind of going into the newborn and infant. And at times you may just see a child come in with a new onset of seizure or prolonged seizure, again, an altered mental status or extreme sleepiness, or you may see a tendency to use only one side of their body, which may flag you to some immediate issue. Interestingly, in the newborns and into the infants, when a stroke affects a newborn infant, the symptoms may not appear until roughly 4 to 6 months of age in the form of a decreased movement or weakness on one side of the body, and that may be something that was not observed until they started to roll front to back and back to front, and then initiating to crawl, and so that it may be fairly delayed when we see the actual presentation of an infant that we're evaluating for stroke. In older children and teenagers, there's at times a weakness or numbness of the face, the arm or leg, usually on one side of the body. There may be some trouble walking due to weakness or trouble moving to one side of the body or due to loss of coordination. There may be some problems speaking or understanding language, including slurred speech, trouble trying to form their words, inability to speak at all, or difficulty in understanding simple directions. And they may present with a severe headache, especially with vomiting and sleepiness. There may be some trouble seeing clearly in one or both eyes. You may get some really different findings in their visual acuity. They may have severe dizziness or loss of coordination that may lead to losing balance or falling. There may be some new appearance of seizures, especially if it affects one side of the body, followed by paralysis on the side of the seizure activity. There may be a combination of progressively worsening nonstop headache, drowsiness, or repetitive vomiting, or they may say that they have had a sudden onset of the worst headache of their life. When it comes to the initial management, it's always with us airway, breathing, and circulation. We certainly want to get the children on respiratory monitoring or cardiorespiratory monitoring. We keep them NPO, nothing to eat or drink while they're being evaluated. They may potentially need sedation for certain imaging and procedures, which will be discussed in a little bit. And we try to get them large bore IVs, peripheral access for medicines. We do the blood draw per our protocol, and we want to have access for medicines and fluids. We also want to make sure the head of the bed is flat, and we want to keep them on strict bed rest, as to not only are they potentially still altered, but we want to make sure that they're not a fall risk and that they don't further injure themselves. So we have a stroke protocol, which we're going to go into, but certainly I want to discuss some of the initial laboratory evaluation. We want to make sure that they are not profoundly anemic and that their counts are okay. So we do a complete, we do CBC. We also do coagulation studies, and we check some baseline inflammatory markers. That helps with some of our differentials as well. We want to make sure we get a urine drug screen, especially for those kids with altered mental status, to make sure there wasn't an ingestion that we don't know about. And we certainly want to make sure that that we have a urine pregnancy test in females over the age of 9 to make sure that that there's nothing contributing, that's not contributing to the symptoms, and also that the medicines that we're going to give aren't going to create any harm to the patient. And we also want to make sure that we do an electrocardiogram to check for any potential arrhythmias or abnormalities of rhythm or rate. So that basically goes over the initial evaluation regarding laboratory screening. I know we're going to get into a little more discussion with radiologic testing and the protocol itself, but I'm certainly open to answer any questions at the end of the panel. Thank you very much.
Hi, everybody. Here's going to start my video. So my name's Anna Thaman. I'm one of the PGY5s in child neurology. I'm going to go over the stroke protocol that we have here at Norton Children's Hospital. The biggest point that we want to make, I think, in discussing the stroke protocol is to let everybody know that we have a stroke protocol and say that this is a evidence-based kind of protocol that we use when someone comes in with concern for stroke. This is not an everyday thing in pediatrics like it is in kind of adult land, but we'll go over this in a little bit more detail. So I won't harp over the things that we've already discussed, but I think it's important to note that to kind of qualify for starting the stroke pathway, or what we lightly call the brain attack pathway, you do need to have at least one of these screening questions. So one of these kind of focal findings or things that can be consistent with stroke. Unilateral weakness or numbness, a facial droop, again, sparing the forehead, so like a Bell's palsy situation. Any trouble speaking, have kind of incoordination or trouble reaching for things or doing kind of coordinating your movements on one side especially, or visual loss or double vision, kind of acute onset. You need all three of these middle criteria. So the symptom onset less than 12 hours, no prior history of Todd's paralysis. That's getting into some stroke mimics, which we might talk a little bit about later, but lots of mimics come through in pediatrics. And this would be if someone has weakness on one side after a seizure. But we don't know that the first time it happens, right? So still sounding the alarm if someone has not proven themselves to have a history of Todd's paralysis after their seizures. And if the problem began or worsens suddenly. Things to know is the time of their last known normal, so not exactly this can be tricky because some people will say, well, I found them like this at what time? But no, we need to know the last time you saw them normal, because those times matter for some of the interventions that we'll get into. Just other family history and other risk factors such as cardiac disease, as Dr. Isacoff mentioned, and home medications, including OCPs. At that time, then the ED would page neurology, and we would all start kind of discussing this as a group. Dr. Isacoff already went over the initial management with ABCs. We did do these neuroprotective measures that he mentioned. That is to basically try to maximize blood flow to the brain. And if someone does have a stroke or a brain injury, we want to maximize the blood flow to get as much oxygen as we can, especially while we're working things up. I did just want to mention on the second page of our protocol, we do have tables looking at the kind of normal blood pressure parameters for males and females, because blood pressure management is a really significant part of stroke management in the acute setting, especially. So just being able, if you haven't memorized the age norms, at least being able to access those, and those are found on the second page of our protocol and like easily obtained, basically, to have someone in their normal range of blood pressure, again, to maximize blood flow. So after we do our initial management, we're going to do an NIH stroke scale by the ED, and typically one of the neurology residents or physicians will come down and get, as soon as possible, a stat CT head without contrast. There are two types of strokes, and this is concentrating on the ischemic type of stroke, when you have a lack of blood flow to a part of the brain. But the other kind of end of things is a hemorrhagic stroke or a bleed. So, this protocol were to kind of stop right here. If you get a CT scan, you see a big bleed, and we say, okay, we know what our problem is. We don't need to go forward with kind of the rest of this protocol looking for an ischemic stroke, because we know what we're dealing with. We have a bleed, or we have some other large tumor or something like that. That would be the reason for this person's symptoms. A word on the NIH stroke scale. This is something that, I think a lot of adult providers know, because adults have so many strokes, but on the ped side, again, we don't use this too much unless someone comes in with concern for stroke. It's basically taking a very specific neurologic exam or parts of the neurologic exam and assigning them a number. So trying to make objective data out of kind of somewhat subjective findings sometimes, but basically assigning a number, because there's a lot of research into, if you have a certain number, meaning your symptoms are worse, a higher number is worse symptoms on this scale, then intervention would be appropriate based on your symptoms. So it's looking at level of consciousness, your gaze, your visual acuity, if you have a facial droop, if you have weakness in your arms or legs, if you have any discoordination, if you have any sensory deficits, especially on one side compared to the other, what your language and speaking is like, if your words are slurred, or if you can't get words out, or you're not making sense with your putting words together. Are you ignoring one side of your body? Those kinds of things, and it makes a scale. It gives you an objective number that you can use going forward in deciding interventions. So again, neurology would be involved at this point. We would be working with the ED and sometimes the PICU already at this point. We would be calling, if they satisfy the protocol parameters so far, we would be calling in MRI techs if they're not already there, if it's not during the day. And saying the magic word that this is concern for stroke and that we need an MRI stat. That would also, if they need sedation for their MRI, that would also involve calling anesthesia if needed in order to sedate the patient to get this MRI, because time is of the essence with acute stroke. Our MRI that we get is the stroke protocol, which includes some particular imaging sequences. And then really you're seeing what your MRI shows and going from there. So there's lots of different options. You could have no ischemic stroke. And then kind of go forward like, okay, if no stroke, what happened? Is it normal? Is it showing something else in the MRI? And kind of going forth in a different direction. You could have I also forgot to mention, you're also going to get an MRA. So you're going to look at the vessels of the head and neck and see if there's any blockages or any differences in the blood vessels. So on the other end of these results, you could have a big stroke, ischemic stroke with a large vessel occlusion, and that could guide you into using things like TPA, which is the clot busting medicine, or going to the IR suite to get a clot removed if there's one that looks removable, after discussing with the vascular neurosurgeon on call. Just a word on TPA. TPA is kind of a big medicine to use. It is one of the more successful things, along with the clot retrieval, that can actually help people who have acute stroke, but it's a very particular medicine. There are a lot of contraindications if someone's on blood thinners at all, if they have a stroke due to any of these things. So bacterial endocarditis, sickle cell, moya, meningitis, those are all things that we would say, hey, the risks outweigh the benefits of using this really strong clot busting medicine. If they have any bleeding on their imaging, if their blood pressure is not able to be controlled, there are lots of things that will say, hey, this is not safe to give TPA. But if we can't give TPA, if they're within the 4.5 hours of onset of their symptoms or their last known normal, this comes back to that NIH. So if their NIH score is greater than 6, meaning that their symptoms are kind of bad enough that the benefit of giving TPA outweighs the risk, and there are no conclusions, and you see a stroke on MRI, then you can give TPA. Just put this in here. It's the second page of our protocol to note that it's we take it very seriously. It takes a lot of monitoring. Again, very particular blood pressure control, very frequent vital checks and neuro checks. And it's just it's a delicate balance of watching someone while they're getting TPA. That's the end of our protocol session. I think I'll hand it over to Dr. Moeller.
Good afternoon, everybody. I am going to talk about neuroimaging in arterial ischemic stroke. I want to thank Dr. Rogers and the Neurology Department for inviting me today. Our goals when we're imaging these patients is, of course, to make the diagnosis of stroke, but also to exclude other causes of an acute neurologic deficit. We want to try to find the cause for the stroke and, if possible, time the stroke, and all of these factors will help determine treatments for these patients. And of course, do it as quickly as possible. We want to preserve as much brain as we can. What we'll do in this session is we'll look at some examples shown here: a neonatal stroke, thromboembolic, which is usually in the setting of cardiac disease, infection causing a stroke in the setting of meningitis, arteriopathies, moya, and dissection. And the imaging techniques that are all helpful in the setting of arterial ischemic stroke include non-contrast HET-CT, CTA, MRI, MRA, and then a newer technique, perfusion imaging, which we'll get to in the end. But really the workhorse in pediatrics is MRI. For a couple of reasons. We want to avoid ionizing radiation in pediatrics as much as we can. And also there's so many stroke mimics in pediatrics compared to adults. So we really need to help diagnose the other causes of the acute neurologic deficit. Our first case is a 3-day-old patient, 3-day-old girl born at full term, no complications at delivery, but had seizures that persisted. So she had a brain MRI. And it's very easy to see this very large acute left middle cerebral artery infarct involving the entire distribution of the middle cerebral artery. And the diffusion weighted images help us to say that this infarct is 30, the diffusion weighted images become more abnormal in the first 30 minutes. So that gives us some information about the timing. And the TT weighted images, and all of this information is extrapolated from adult literature, but in general become positive at around 8 hours after the stroke. Now, neonatal arterial ischemic stroke is a subtype of perinatal infarct in which the patients present in the neonatal period. And the cause is somewhat controversial. They think possibly it's a thrombus that crosses from the maternal placenta through a patent foramen ovale. In the same patient, the gradient image helps us determine that there's no hemorrhage. And the MRI shows decreased or deficient middle cerebral artery on the affected side, but there's no focal embolus present at this time. The next case is a 5-day-old boy who came to the ER with apnea, and his septic workup revealed Group B streptococcus in his CSF. And you can see lots of tiny infarcts in the basal ganglia and deep white matter on both sides with restricted diffusion and dark signal on the ADC. So these are small infarcts in the distribution of lenticular striate or small perforator arteries. A very similar patient, a 7-day-old boy with Group B streptococcus meningitis, arteritis leading to these small infarcts. Interestingly enough, these very small vessels don't really show up too well on MRA, and all the other vessels look normal. The next patient is a 15-year-old girl with known sickle cell disease and known moya-moya, and this is just to show the imaging findings in the setting of moya-moya. As we look at the T2 weighted images at the base of the brain, we can see all these little punctate flow voids filling the basal cisterns, and these are those collateral vessels making up for the stenosis in the supraclinoid ICAs and middle cerebral arteries. Also in this patient, there's very small watershed infarcts, and these present as a string of beads, sort of sagittal, parasagittal, stripe-like areas of abnormal T2 signal in the white matter between the anterior and middle cerebral artery. In the same patient on the MRA source images, you can see all the lenticular striate collaterals in the basal cisterns. You can sort of appreciate what we call on angiography, a puff of smoke from those collaterals on the MRA images. There's abnormal stenosis of the supraclinoid ICAs on both sides. The middle cerebral arteries aren't well visualized. In this case, it's interesting because this patient had an encephalodural arterial synangiosis. So this is a superficial temporal artery, which the surgeons isolated and laid on the surface of the brain. So you can sort of see where the artery crosses the skull here to give the patient collaterals. Here's another patient with sickle cell disease, a 4-year-old girl who presented to the emergency room with seizures. On our non-contrast head CT, you can see the subtle changes of an acute arterial ischemic infarct in the distribution of the middle cerebral artery. We have abnormal low density. It has a wedge shape. It's involving gray and white matter in the basal ganglia. There's no hemorrhage, not a lot of mass effect at this time, but 3 days later, the mass effect peaked, which we know typically peaks at about day 3. Lots of swelling. She needed a decompressive craniectomy. And here at day 7, this is just to illustrate the stroke findings in the subacute phase. On T1 pre-contrast images, you can sometimes see this, what we call laminar necrosis, or this T1 hyperintensity in the cortex, sort of following the cortex in the area of the infarct. And there's lots of edema on the flare sequence. Her MRA at day 7 looked like maybe it was going to be a moya-moya. You can see some stenosis in the middle cerebral arteries on both sides. The supraclinoid ICAs look pretty good. But at 4-year follow-up, her MRA was completely normal. So sickle cell disease patients do have an increased incidence of moya-moya and a stroke in that setting, but they also just have an increased incidence of stroke even in the absence of moya-moya disease. The next patient is a 12-year-old girl who was in an ATV accident. She had lots of facial trauma and was concussed, so she had a non-contrast head CT. You can see facial bone fractures, lots of secretions in the sinuses and airway. And some pertinent negatives at this time for this patient were that the skull base, including the petrous canal for the petrous internal carotid artery, was completely normal, and the brain was completely normal. 2 days later, she presented with decreased movement in her left leg, and you can appreciate an abnormal arterial ischemic infarct in the distribution of the middle cerebral artery, arterial division, anterior division. So in a patient with a recent history of trauma, and a pediatric patient especially, this is arterial dissection until proven otherwise. So she went back to radiology for a CTA, and sure enough, we were able to see the dissection in the internal carotid artery on the right side. Here's the normal internal carotid artery on the left. It's markedly narrowed on the right, and it's very irregular and has intermittent narrowing in its entire course. on the coronal and sagittal CTA images. Here is a 13-year-old boy with congenital heart disease. He has a bicuspid valve and he went for balloon valvuloplasty. And when he woke up, he had decreased speech. So he went right to MRI, and you can see an abnormal acute infarct in the left caudate nucleus and corona radiata. And what this case illustrates is that the flare is completely normal. And we call this a DWI flare mismatch. And this helps us to say that the infarct is less than 4.5 hours old, that perfect window that Anna just talked about for TPA treatment. This is a 9-month-old girl who presented to the emergency room with right-sided weakness. On further questioning the patient, we were able to find out that the weakness started around 10 days prior, after she had cardioversion for AFib in the setting of Wolff, Parkinson, White. So here she is 10 days later presenting with a weakness, and at this time her MRI shows a subacute infarct. Here's our pre-contrast T1 weighted images. This patient doesn't have a laminar necrosis that we saw earlier, but you see the volume loss and the encephalomalacia and gliosis. But with contrast, you can see abnormal parenchymal enhancement in that same distribution. So this is a common finding in the setting of subacute infarct. And in general, it can present as early as 3 days and persist for as late as 3 months. Here's the same patient just reviewing the chronic infarct findings that we see at imaging. We have encephalomalacia, gliosis, brain resorption, volume loss, and then Wallerian degeneration or a small brainstem on the ipsilateral side. The next patient is a 15-year-old boy who presented with acute left-sided weakness. He has a history of congenital heart disease and questionable compliance with his aspirin therapy. So he presented within 90 minutes of his weakness. In his non-contrast head CT, you can see an abnormal hyperdensity in the right middle cerebral artery, consistent with thrombus. Higher up, you can see some chronic watershed infarcts, and at CTA, you can see decreased enhancement in those vessels in the right hemisphere compared to the left. He went straight away to MRI, and we can see acute infarct in the basal ganglia and right parietal lobe, and the flare DWI mismatch, so we're less than 4.5 hours in our stroke. This patient had a small stroke volume and was considered a good candidate for a thrombectomy, and he went right to the IR suite. And by this time, a lot of the clot had propagated further, but the interventionists were able to get the clot out. And here was its final infarct size, which is actually smaller than how he presented. So this is a really great outcome for this patient. So I wanted to use that case as just a way to talk about large vessel occlusion and the use of perfusion imaging, which is coming down the pike in pediatrics and widely used in adult imaging. And I think we all remember this picture from training, and it's really just helpful to drive home the point of when you have a blockage in your artery, you have brain that dies right away, and you have other portions of brain that at risk for further injury. And this will vary from patient to patient depending on collaterals, but we really want to try to salvage this brain if we can. So at imaging, the gold standard for core, the best gold standard that we have is actually what we see on the DWI. It's not perfect. Some DWI lesions are reversible, but most are not and are considered the gold standard for core imaging. But as structural imaging, we really aren't seeing the penumbra. We only see the core infarct. In our patient that we just looked at, we could sort of surmise the penumbra because we have the small infarct, but we have the clot that's in the proximal MCA. So we know that there's a big area of penumbra in that whole MCA distribution. Other ways that you can kind of get a penumbra are what we call core clinical mismatch. So you have a patient with a small infarct at DWI, but you have a very large penumbra on clinical exam. So a larger deficit clinically. And then perfusion imaging is an attempt to try to get at that penumbra non-invasively. So perfusion is a newer technique. We use it for other things like tumor imaging, post-tumor treatment imaging. But in the setting of stroke, it's thought to be most useful to try to find that penumbra for treatment. Different kinds of perfusion imaging include CT perfusion. There's 2 types of MR perfusion that use contrast and another type that doesn't use contrast, dynamic contrast enhanced dynamic susceptibility, and arterial spin labeling. Here's an image from an MR perfusion patient, just showing the cerebral blood flow pictures, what they look like. The way these images are obtained for CT perfusion, contrast is injected into a peripheral IV. It gets into the brain and perfuses the capillary bed in the brain parenchyma and then washes out. And then we measure by scanning the patient over and over and over again, we measure the change in the density of the brain over time, coming up with these parameters. And MR perfusion uses the exact same principles, but with MR, the contrast injection with gradient sequences causes a dropout in signal, but the curve is otherwise just upside down, and we get the same parameters. These are given in a format that we're all used to looking at, axial images showing all these different parameters, cerebral blood volume, cerebral blood flow, mean transit time, and Tmax. So just in general, this is an oversimplification, but the core infarct will have a markedly decreased cerebral blood flow, and the penumbra will have alteration in the time parameters. There is artificial intelligence called Rapid that's very commonly used currently in adult hospitals, in which all that data is put into this software and these images are spit out. And they're actually even given to neurosurgeons and neurologists on their phone to make these decisions about treatment, thrombolysis or thrombectomy. And you can see how easy they are to read. You can see the size of the core, the size of the penumbra. We're looking for an ideal ratio so that the penumbra versus the core is at least 1.8 times the size of the core. And also you want a relatively small volume core to make thrombectomy worthwhile. And the same exact artificial intelligence software can be applied to MR perfusion, giving you the exact same pictures. Arterial spin labeling is a type of perfusion imaging that does not use contrast. And this is an MR technique in which we obtain control images by imaging the brain. And then we tag red blood cells in the neck and then go back and image the brain. The labeled images is subtracted from the control, and what we're left with is just the tagged red blood cells, which gives us a picture of cerebral blood flow. Here's an example of a normal arterial spin labeling imaging in a 10-month-old girl. And just a couple of examples. We're just getting started using arterial spin labeling, but here's one example. A 2-year-old boy was riding a bike with an object in his mouth, and he fell with the object penetrating his posterior pharynx. So at CTA imaging of the neck, you can see the abnormally small left internal carotid artery compared to the right, the abnormal gas in the soft tissues, complete cutoff of the internal carotid artery on the left. The brain MRI looked pretty good. There were a couple of small areas of ischemia, but at ASL image, there was a large area of decreased cerebral blood flow in almost the entire left cerebral hemisphere, involving anterior and middle cerebral artery branches. And at the MRA, you can see that we're not seeing the internal carotid artery at all compared to the normal internal carotid artery on the opposite side. Here's a 2-day-old boy, again showing a neonatal infarct with abnormal restricted diffusion and some subtle edema on the T2 weighted images. In this case, nicely illustrated what we call luxury perfusion or post-ischemic hyperperfusion, where we have increased perfusion in that MCA distribution. At first glance, this seems like it would be a great thing to have, but actually, since that brain is already injured, it's not ideal. The patient might be at risk for more swelling, hemorrhage, and at best it shows us that there's some kind of disconnect between metabolic needs and cerebral blood flow. The last case is a stroke mimic. This patient presented with migraine, headache, and aphasia. You can see on the arterial spin labeling that there's hemispheric decreased perfusion in the left hemisphere compared to the right, a finding that we're seeing more and more frequently in patients with migraine and aura. And if you go back to the SWI sequences, you can also see in the sulci of that same hemisphere, we're seeing more hypointensity within the vessels. And this is just increased hemoglobin within the vessels because the slower transit time is resulting in increased extraction of the oxyhemoglobin. So just a secondary finding of the decreased cerebral blood flow. So in summary, arterial ischemic infarct is uncommon in kids compared to adults, but it's not rare. We do see it. Diagnosis is often delayed and stroke mimics are more common. Causes in pediatric patients that we looked at were cardioembolic, infection, meningitis, trauma, sickle cell disease, moya. There's others that are more rare. And capturing treatable causes early is ideal and is current focus for lots of children's hospitals, including ours. And treatments rely on an optimized imaging workflow and diagnostic interpretation. Thank you.
Back to a few quick clinical cases highlighting different parts of the actual protocol.
Dr. Thaman, sorry to interrupt you, but your audio is sounding a little different than before. Is there anything different about your setup? It's about the same. Try again.
No.
It's kind of getting a lot of feedback.
Weird. Everything.
Anybody have any troubleshooting ideas?
If not, Anna, you can run the slides and I can talk since I know what's going on there.
Okay, that would be great. Thank you.
All right, so we just have a couple of cases since we do have a little bit of time left to highlight the points that were made by the team so far in terms of acute ischemic stroke. The first case is an example of a 15-year-old male who has a history of a congenital heart disease with hypoplastic right heart syndrome, has had surgery for that, again, questionable compliance with home aspirin, who presented suddenly after slumping off the couch and not acting right. On arrival, his exam was fairly significant with left-sided hemiparesis, right gaze deviation, and left-sided sensory neglect. So fairly obvious presentation for a stroke, basically. So his NIH stroke scale was 15, which if you remember the numbers that Dr. Thaman talked about, it's somewhere in the middle. It's a decently high number. Next slide. So he had a brain MRI, and I think this is the same MRI as one of the ones that Dr. Moeller showed, but you can see this is a diffusion MRI, and on the right side, there are areas of diffusion restriction in the parietal lobe as well as the basal ganglia. Because when you think, if you look back and look at his presenting symptoms, he sounded like a full MCA infarct, whereas there is a mismatch on his MRI here. So there is a diffusion clinical mismatch. So his clinical picture is definitely worse than what his diffusion looks like. And he had presented within the acute time period, less than 4.5 hours of onset. So he met the criteria and didn't really have any contraindications for treatment. So he underwent hyperacute therapies. He received TPA and actually went for endovascular mechanical thrombectomy. Now, neither of these treatments are FDA approved for kids, but we use them off-label a lot for kids that meet appropriate criteria. And he did really well after receiving this treatment. If I remember correctly, after he was by the end of his hospital stay, his NIH stroke scale was either a 0 or a 1, down from 15. Next slide. So this, again, going through our stroke protocol that Dr. Thaman had shared, when you look at where he falls on the protocol, he presented with unilateral weakness and facial droop, which is meeting the screening questions. He does meet all the alert criteria. Symptom onset was less than 12 hours, no prior history of TODS, and then problem began acutely. And then in further history, he does have a history of cardiac disease, which is a risk factor, which is why We went down the protocol. His stroke scale was 15. And we looked at the MRI, kind of going on step 3 here. And then on step 4, he actually met the last one, ischemic stroke with large vessel occlusion, which is in the M1 territory for him, which is proximal MCA territory. And because of this, he met the IV TPA criteria, he met the clot retrieval criteria, and actually underwent both. So it was a slam dunk for acute stroke who received treatment. And this is the kind of case why we are so much focusing on the protocol and why we want it to be a well-oiled machine where it runs through the protocol. Next slide. The second case is a 14-year-old male who has a history of PFO. He presented with left-sided weakness. The night prior to presentation, he was not feeling right, but family said, okay, that's fine. Maybe he was just too exerted. He complained of this, dizziness as well. They thought he was out in the sun too long, went to sleep. When he woke up, he developed left-sided weakness and face seemed droopy. This is when family sought medical attention and brought him to the emergency room. On arrival, he had a left-sided hemiparesis, left-sided facial droop, and mild dysarthria. Did not have any aphasia. His NIH stroke scale was 5. So if you remember the numbers, it's fairly low on the NIH stroke scale. Next slide. And he urgently got a brain MRI, and looking at this brain MRI, it's a diffusion scan again. On the right side, there's an area of diffusion restriction that's clear in the basal ganglia here. But then it looks like the MC territory, but when we got the CTA as well as when we got a CT, you can see this area of faint hyperdensity here, which basically tells you that there is some concern for bleed there. He actually ended up having a dissecting aneurysm at the right MCA bifurcation. So because it was something, it was a dissection, he did not get TPA. There was bleed, again, would be a contraindication for TPA. Treated with aspirin and Plavix, supportive care at that time, and over time he did undergo vascular intervention for embolization, for pipeline embolization of the aneurysm. Next slide. So again, kind of looking through the protocol, met these criteria in box 1, met all the alert criteria, and had a history of PFO, which unlikely was to be contributory in his case. But with all of these, really, you just need criteria in box 1 and all 3 criteria in box 2. NIH stroke scale was 5. Looking down below, got a scan quickly, and that showed an area of infarction. He kind of meets the 3rd criteria here, where he had concern for dissection with ischemic stroke, and therefore did not get any further treatment, at least with hyperacute therapies. Third case is a 16-month-old female. So now we're in the territory of toddlers who are fairly challenging in terms of presentation and just identifying symptoms. She presented after falling off the bed about 2 to 3 feet, so not too bad, and just hit her head, then pass out, then throw up. But then the parents noticed that she had a facial droop and stopped talking. Her initial exam showed left hand preference and right facial droop, which was new, and not really talking to the examiner, but she's a 16-month-old who's in the healthcare setting. So is it related to the stroke, or more likely, is it related to just anxiety? Likely just anxiety. So this again highlights the picture that it is difficult to examine kids in this acute setting. So you work with what you get, but certainly this facial droop would be concerning. And at stroke scale, questionably 3. Again, you didn't get a full exam. So she got a scan which shows these area of diffusion restriction in the bilateral basal ganglia. So she had bilateral basal ganglia ischemic infarcts, which is actually there's a very uncommon entity that's reported where toddlers, typically less than 2 years of age, a lot of times they might get a little bit of head injury. So something like this, where they bump their head or fall from the bed or something. And after that, they have basal ganglia ischemic infarctions. It typically tends to be in kids who have lenticular striate vasculopathy, or if in retrospect, if you look back in their CTs, they might have areas of calcification in there. That might not always be there. And this entity is really very specific to this age group of little toddlers around 2 years of age. And I think in the past 3-4 years, we've had about 3-4 cases of this. she's done really well. So looking at the brain attack pathway, again, in the box, meeting criteria of facial droop, meets the alert criteria, nothing in the third box. Stroke protocol was activated. Stroke scale was fairly low. So even if she met all the other criteria, your chances for needing intervention such as TPA or hyperacute therapy would be low. MRI, going down the pathway, you look at the MRI that shows the infarct. So she falls in that second box where she had an ischemic stroke with open vessels. So the management at that point is supportive. And if you use aspirin in this age group, if they're less than 15 kilos, the dose of aspirin is about 3 to 5 per kilo. And that's what she was treated with. Next slide. Let's see. So case 4 is a 16-year-old female, history of severe iron deficiency anemia, on OCPs, and has a PFO. So some risk factors for having stroke there. She presented with a few days of on and off left facial numbness and left facial droop. So didn't really seek attention in the beginning, but when this persisted, came to the ER. When she was seen in the ER, because her symptoms were intermittent, her exam in the ER was totally normal. So NIH stroke scale was 0. And I actually remember seeing her in the ER. I think she had hyperreflexia. That's about it. And with hyperreflexia is not a part of the stroke scale. So this, again, can highlight one of the things that we see a lot in pediatric stroke is that the symptoms can be stuttering. They can be very intermittent on and off, and they can easily be missed. Again, over the past couple of years, we've had a few kids present to the ER where by the time they presented to the ER, their symptoms were totally resolved. And then you get a scan and they've had a stroke. Next slide. So she got a brain MRI, and you can see that there's areas of diffusion restriction, kind of these little patchy dots on the right side of the brain. There's one prominent one, but then there's other little ones also. She has lots of risk factors with her iron deficiency, OCP use. I think she was also obese. But despite all those risk factors, her vessel imaging is not in the slide, but her workup revealed that she had moyamoya disease. She didn't have any risk factors for moyamoya. Over time, she underwent surgical treatment with EDAS. And I haven't seen her for a while. I believe she's done well, at least after the treatment. Before surgery, she was on aspirin. So again, looking at the protocol again, so she fits criteria in the first box, meets the criteria in the, doesn't meet all the criteria in the second box because her symptoms were over 3 to 5 days. NIH stroke scale is 0, got the MRI, showed an acute stroke. And again, this was ischemic stroke with open vessels. This case again highlights that even though our protocol says that you have to meet all the 3 criteria in the middle box on the top there, sometimes even if you don't meet it, if the suspicion is high enough, you can still call neurology and discuss about activating the BAT or not. In this case, even if the BAT was not activated, she would have gotten a scan regardless. And in her case, activating a brain attack versus not really wouldn't have made a difference in terms of what your management would be necessarily. Next slide. Right, that is the end of our slides. Dr. Rogers, do we have some time for questions?
Yeah, we can take about 5 minutes for questions, then we'll have a 10-minute break.
Okay. I don't see any questions here, but I have a couple of questions for Dr. Isacoff and Dr. Thingman and Dr. Moeller. The first one, I'll let Dr. Isacoff take this. I know that one of the challenges we see in ped stroke is stroke mimickers. Would you go over some of the pediatric stroke mimickers that we see? And what percentage of stroke alerts tend to be mimickers or false alerts?
Sure. So some of the differentials that we may see, excuse me, they may be migraines, like complex migraines. You may have like a Bell's palsy, syncope, or something that's more psychogenic. If there's certainly some alarming differentials like CNS tumors, intracranial infections, abscesses, demyelinating diseases, cerebralitis, again, something inflammatory, or you could have Tau's paralysis after a seizure. So those are certainly more differentials. Mimickers, I believe 60 to 80% of within some of the prior, I guess, information. But certainly the initiation of the stroke protocols in different children's hospitals have increased availability of specialists and availability of MRI. And even if there are, I guess, a lower number of strokes that are identified, there are some also pretty major neurologic conditions based on the differentials that are picked up fairly timely. And so, better outcomes.
And then this, I think Dr. Moeller might be able to answer this question. Does perfusion imaging help in differentiating stroke versus TOTS paralysis?
I think it can be helpful as a sequence, not by itself, but when you add it with everything else. So if everything's normal, then you can rule out your arterial ischemic stroke and then move to your ASL to try to figure out if you have TOTS paralysis. And I think with TOTS paralysis and migraines, the interesting thing about the ASL imaging is it's a whole hemisphere, so it's not really vascular territory. So it's an interesting finding that we're still learning about. One of the names for it is cortical spreading depression, like a whole hemisphere just has decreased metabolism and perfusion. So yeah, I think so, but you have to look at all the sequences taken together.
And do we have availability of perfusion imaging at our center?
We're using ASL currently, and we're just sort of waiting for not that we're waiting for other hospitals, but right now that is the standard of care for pediatric perfusion imaging. CT perfusion has too much radiation dose, and MR perfusion requires large bore IVs, power injectors, and just a commitment that so far isn't been made in children's hospitals, including ours.
When I was on service last couple of weeks back, you did some nice perfusion weighted imaging. It's the first time I've seen that. I remember I requested, I first saw, I think, a perfusion weighted image about 15, 16 years back at a radiology conference at the Board Club. This guy from Case Western had come and given a talk. And then it took 15 years before I saw one at Children's ourselves. But there were some beautiful images, and I talked to you about a couple of those patients, Karen. We had a migraineur and and a patient with that had a concussion also, and there were some interesting patients we saw. So Arpita, we saw some nice perfusion weighted imaging.
Yeah, I think because we're doing it on all cases, then that'll just help us learn.
Yes.
That when it's a problem-solving situation, we can use it.
I see a question from the audience. Can you help us differentiate clinically between stroke and Bell's palsy? When do you do imaging versus wait and watch? Obviously don't want to miss a stroke, but have seen Bell's a handful of times in practice. Dr. Thayman, do you want to answer this?
How am I sounding? Is my microphone working?
It is working now.
Nice. So this is a great question. I think a really important one because Bell's palsy, especially lately in the summer months, I feel like we've seen a ton of it lately. So it's a little counterintuitive, but I think Bell's palsy is going to involve the whole side of the face because you have just peripheral involvement. The problem is with a peripheral nerve. So the whole face, forehead down to mouth droop. On the other hand, when you have a stroke or an upper motor neuron lesion, so a problem in the brain, you're just going to have involvement of the lips. So the forehead wrinkles, I think I do have enough wrinkles up there, will look normal on both sides of the face because you still, even though you have a problem down here and on this side of the brain, you still have, the side of the brain, you still have dual innervation from the other side of the brain to the forehead. So it's a really interesting, I think, convenient distinguisher to be able to tell, hey, what is an upper motor neuron problem versus a lower motor neuron problem, aka like a stroke classically versus Bell's palsy, because there's a huge difference in how we treat those, right? Bell's palsy, we're going to say, hey, you're okay. Maybe you have some steroids and some acyclovir, and we'll just see you later. We'll follow up and see if the things get better. Versus a stroke. Versus kind of, which is sound the alarms, do all the things, call all the people. So again, just to summarize again, stroke or a brain problem is going to be just the lower side of the face versus a Bell's palsy which is going to be the whole upper and lower side of the face, so the whole half of one face.
So additionally, patients with the Bell's palsy may frequently have some retroauricular pain also. They complain of some discomfort there. And additionally, in a patient that's had a stroke related to an upper motor neuron lesion, barring a very rare situation where you just have an ischemic stroke affecting the facial nerve nucleus, if it's a MCA stroke, you're usually going to have your right upper extremity and lower extremity involved also. So look for a pronator drift very carefully in these patients. Look for distal weakness of the fingers, and that can usually lead you in the right direction also.
All right, thank you. That was an excellent panel discussion. Really appreciate it.